All right, let's talk about pheochromocytoma. Pheochromocytoma refers to a group of usually benign tumors known as catecholamine-secreting tumors. These develop from specialized cells called chromaffin cells, which are found inside the adrenal glands and along the sympathetic nervous system. Although they are quite rare, they are well known for producing excessive amounts of hormones, especially adrenaline, which may cause the classic triad: headaches, intense sweating, and tachycardia. Eventually, this can progress to serious and potentially life-threatening complications, such as mental status deterioration and hypertensive crisis. The adrenal glands are two pyramid-shaped organs located in the posterior abdomen, just above the kidneys. Each gland has two main regions, the cortex and the medulla. The cortex is the outer layer and produces steroid hormones, mineralocorticoids, glucocorticoids, and androgens. The medulla, located in the center, contains the chromaffin cells, which secrete catecholamines, mainly adrenaline and noradrenaline, in response to stress. These hormones stimulate the sympathetic system to trigger the fight or flight response and ultimately produce the characteristic catecholamine-related symptoms. Therefore, when there is an overproduction of catecholamines, the clinical picture results directly from this excess of sympathetic-mediated symptoms. Although many pheochromocytomas occur sporadically, some are associated with hereditary conditions, such as multiple endocrine neoplasia type 2 and von Hippel-Lindau syndrome. Whether hereditary or sporadic, most of these tumors are benign, with only about 10% exhibiting malignant potential. When considering clinical features, the classic presentation includes episodic headache, intense sweating, and tachycardia. However, in practice, the most frequent finding is hypertension, which may occur in sudden paroxysmal episodes or as sustained high blood pressure. Other symptoms include palpitations, tremor, pallor, anxiety, and weight loss. In rare and severe situations, patients may experience a pheochromocytoma crisis. This life-threatening emergency consists of severe signs of systemic deterioration, including profound hemodynamic instability, either severe hypertension or hypotension, accompanied by hyperthermia, altered mental status, and multi-organ dysfunction. After we see the clinical picture, we then take a look at the lab findings. Measuring epinephrine and norepinephrine directly in the blood is often unreliable and inaccurate because their secretion is episodic. It fluctuates from minute to minute, and serum levels may appear normal between episodes. To address this problem, we measure their more stable metabolites, metanephrine and normetanephrine. These compounds are produced not only when catecholamines are released into the bloodstream, but also continuously within the tumor itself. That's why the diagnosis relies on measuring either plasma-free metanephrines or 24-hour urinary metanephrines. If the results are more than 3 times the upper limit of normal, this is considered diagnostic for pheochromocytoma. Once biochemical evidence is confirmed, imaging studies are used to locate the tumor. In about 95% of cases, the tumor is found within the abdominal cavity. Therefore, a computed tomography or magnetic resonance imaging of the abdomen and pelvis are the preferred methods for identifying these group of tumors. The cornerstone of pheochromocytoma treatment is surgical removal of the tumor. However, it is important for the surgery to be preceded by adequate medical preparation. The key principle is that alpha-adrenergic blockade always comes first. This is crucial because it protects the patient from severe hypertensive crises caused by the massive release of catecholamines that can occur during tumor manipulation and surgery. Medications such as doxazosine are used to block the effects of these hormones on blood vessels, allowing them to relax and preventing dangerous spikes in blood pressure, and it is typically administered for 1 to 2 weeks. Once adequate alpha blockade has been achieved, a beta blocker can be added if tachycardia or arrhythmias persist. The surgical procedure is called localized adrenalectomy, and it involves removing the affected part of the adrenal gland. This approach is highly effective for small, solitary, intraadrenal pheochromocytomas and represents the treatment of choice in about 90% of cases. I hope this video helped you understand pheochromocytoma in a clear and structured way. If you found it useful, don't forget to like, comment, and subscribe for more medical content. Thanks for watching, and see you in the next one.